Hi guys, I hope you're well and welcome back, or if you're new here, thank you for tuning in. My name is Laura. I thought I would introduce today's video because it is a little bit different. So I'm basically working with Bourn Hall Fertility Clinic on some content to raise awareness of infertility and IVF. If you have followed me for a while, you will know that I've been through miscarriage, infertility and IVF most recently. So I'm very clued up on these things, but obviously I can't answer your medical questions. So we thought it'd be a really good idea to get a nurse and a doctor from the clinic who have years of experience in infertility and IVF and treating patients to answer your questions. So I asked over on my Instagram a few weeks ago for some questions from you guys, and those are the ones that we're going to be answering in this video. I really hope it helps anyone out there about to embark on IVF, or if you're thinking about IVF, or if it's just in the back of your mind and you just want to know a little bit more about it. Got a nice positive uplifting Q&A for you, and I think that's what we need more of when it comes to IVF and infertility, if we can. Anyway, I'm going to stop rambling on. Let's get straight into the Q&A. I really hope that it's helpful and I hope that you enjoy it. So yeah, let's go. Here's the Q&A. Hi everyone, so today I am at Bourn Hall and we have a Q&A. You guys have submitted some questions, so I'm going to ask these lovely ladies. So first I thought it'd be really good if you could introduce yourself and what you do at Bourn Hall.
So my name's Leona and I'm the lead nurse here at Bourn Hall. I started at Bourn Hall about 6 years ago, but originally I did train as a fertility nurse at Bart's in London. I was there for about 10 years, so in total it's been about 16 years I've been working as a fertility nurse.
Wow. And my name is MISCARRIAGE. I'm one of the consultants here at Bourn Hall. I've been at Bourn Hall for over 3 years now. But I trained as a gynae doctor in the East Midlands area, so where I've been doing level 2 fertility work during my whole training. So yeah, I'm very happy to be at Bourn Hall, being able to do what I want to do full time.
Oh, lots of experience between you both.
Yes.
Which is always good.
It's always good.
Yeah. Right, so I guess we'll just go straight in with the questions. So the first one is there anything you can do to improve sperm and egg quality?
So there are certain things that we can do to help with egg and sperm quality. Simple lifestyle factors are ones that we can discuss quite a bit in our consultation. So ones for general for both egg and sperm, so things like reducing alcohol, no smoking, fertility supplements, which is a big market out there for, but there is some medical evidence behind them to help with improving egg and sperm quality. Minimal or reducing the caffeine intake as well. So these are things that have been shown to help. And then there are some more finer or more detailed things that we can do to talk specifically for sperm. And they're things like reducing scrotal temperature, so reducing heat, things like saunas, steam rooms and hot baths, keeping the underwear more loose rather than tight. Yeah. So these are things that are simple things that we can try and do to help if the sperm quality is potentially borderline. And then specific vitamins for women, maybe who are a bit older, 37 and above, we would tend to advise something like coenzyme Q10, which has got some medical evidence behind it to help with their quality in particular.
Okay. And is it good to start that a little bit before treatment, obviously? So if you know you're having IVF, then to be a bit more aware of that?
Yeah, ideally we'd say for about 3 months leading up to treatment would give it give it some time for it to work, especially because the sperm cycle is about 3 months as well. Okay. So it just makes sense for 3 months leading up to treatment to be on and doing these factors to try and do whatever you can to improve the sperm and egg quality.
Okay. What are the success rate stats? So for example, percentage of those who get pregnant / how many rounds it takes on average, etc.
That one's a little bit more tricky to answer, just because obviously it's a bit different for
factors involved.
Yeah, of course. It's quite personal, I guess.
It is personal. Success rate is very, very age related, dependent.
Yes.
So you'll notice that on our website, the success rates are different for women who are 37 and below and 38 and above. But our success rates for Bourn Hall are above the national average, which we're very proud to say. And it's probably in the region of around 40 to 45% in general.
Yeah, and sometimes it's good not to focus so much on that, isn't it? When you're about to go through it, it's kind of good to kind of keeping your
I think it's really important not to be so focused on success and be more about what the clinic is like and how you feel about the clinic.
Yeah, definitely.
Because I think, you know, your experience through your treatment is what's important.
Yeah.
And that, you know, rather than looking at the success rates of each clinic, I think it's better to go and get a feel for the clinics and see if you feel that's going to be suited to you.
Definitely a good gut feeling,
Yeah.
is what I always
Yeah,
say.
absolutely.
It helps,
Absolutely.
definitely.
Yeah.
Statistics are helpful sometimes, but actually it is just a number, and you're the one going through the treatment, and it doesn't. Sometimes it becomes irrelevant what the statistics are out there.
Yeah, definitely. So next up we have someone that's previously had IVF at Bourn Hall, and she's asked what is the criteria at Bourn Hall for donating eggs?
Women have to be under 35 and have a very good ovarian reserve. So that is a blood test that we do called AMH. Ideally it should be 20 and above, and that is just for us to be able to get a good enough number of eggs from that woman to be able to donate in the first place.
Yeah.
They need to be a non-smoker, and ideally their BMI needs to be as close as possible to 25, but under 30 for sure.
Okay.
So, yeah, they're the medical conditions that
You set.
That we set, yeah.
Right. Okay. So the next one is, who is the ideal person for IVF? On paper, I guess.
Yeah, that's also a bit of a tricky question because there is no ideal person for IVF. We can treat women and couples from various different backgrounds or different ages with different medical conditions. Of course, women who are... IVF is very much driven by female age and egg quality. So of course, if the woman is younger and has a higher ovarian reserve, then of course that is always going to be better, and it will increase your chance of success. But I wouldn't like to class an ideal person, because I think that would eliminate a lot of people, and it is about tailoring their treatments individually.
Yeah, definitely. You can't really describe who the ideal person is until they have it. I guess you don't.
Exactly. We have a lot of success with older women who have got a very low ovarian reserve, or anyone in between. So I think it's just remembering. I always tell my couples that it is driven by female age and ovarian reserve. So equality in egg number is what drives the success, but there are a lot of other factors that come into play.
Yeah. Okay. If IVF is unsuccessful, what are the next steps at the clinic?
So if the treatment is unsuccessful, normally they will contact the nurses and tell them the result of their pregnancy test. We normally send confirmation to the doctor, who then does a letter to the patient explaining what the next steps are, which is mainly to book a consultation for a follow-up to go through your last treatment and basically decide what the next steps are. Are you going to pursue more treatment? Are there changes that we can make to your next treatment to make things work better? But yes, basically they would have a doctor's consultation, we would go through all of what happened on their last cycle, then we would decide where we go from there.
Right, okay, so if there's any changes that need to be made?
Or they can be made with consultation with the doctor, because they obviously look at what happened on the previous cycle, how the patient has responded, is there any changes we need to make to drug dosing, could we make more follicles, could we get more eggs, or could we get less, because some people do over respond and we may need to get less eggs next time. So there's looking at all those things and just trying to change it to make it a better cycle for the next cycle.
That's quite good to know actually, because I think if you have an unsuccessful round, it can be you can get quite low about it.
Yeah, it's demoralising,
nothing's going to change.
Yeah, actually, and I think if you look at sort of the data, I think people are actually more successful through second and third cycles than they are first cycles, because it sounds ridiculous, but it is very trial and error your first cycle. We've never done this to the patient before, we've never tried these drugs, we don't know how you're going to respond, so it is a little bit new, and then obviously you gain information from that. So I would say to patients, don't feel too upset if you don't succeed with your first cycle, because there's a very good chance that you will succeed with your second or third.
Yeah, definitely.
Absolutely. I couldn't say it
There
better myself.
you go, said it well. So, and the next question is, how do you manage IVF for those with a history of unexplained recurrent miscarriage?
That is quite tricky as well, just because unexplained recurrent miscarriage is a huge topic in itself. And technically IVF is very much catered around trying to get the couple pregnant in the first place. And recurrent miscarriages have got a huge amount of causes, but as the term suggests, unexplained recurrent miscarriage, there's a huge percentage of them that do go unexplained. there is no real medical form of treating them either, so therefore we're a little bit limited as to what we can do in IVF.
Yeah.
But there are some empirical treatments that we can try, something simple like a baby aspirin and with blood thinners, and these are medications that a lot of clinicians use for recurrent miscarriage, so we can add this into our IVF protocols. But there are other areas of the IVF process that we can do that we can try and address. So things like looking at the womb and looking at the lining, making sure that's receptive and making sure that implantation can go without any problems, and looking at other things like the thyroid status before IVF treatment. So there are definite areas that we can look at in more detail and optimise before going into IVF treatment to help those who have a problem with recurrent miscarriage.
Okay, that's good to know. So next up is a similar question, but is the treatment plan different for those with severe endometriosis?
Yes, so severe endometriosis, another huge area in gynecology, which is a real problem, especially with women who are wanting to try and conceive. Very difficult condition to treat. There is no treatment really for it, it's just about managing it, but very difficult when it comes to fertility because it's a constant balance between being sparing in your treatment to try and retain as much fertility, but also taking into account their quality of life, which does sometimes often need more drastic types of treatment, such as removal of reproductive organs. But when it comes to IVF, we will certainly want to go through the woman's history, especially if it's severe. They must have had some kind of hospital treatment in before, so accessing those records, seeing what their previous surgery is like. And there is a specific protocol that we use that is more catered for women with endometriosis and put them on like a suppression. First, so we would like to put them in like down regulation medication to help basically keep the endometriosis as quiet as possible. And making sure that we scan them before the treatment to make sure that the ovaries are accessible. That's another massive area in fertility and specifically IVF, that we have to be able to access the ovaries safely to be able to collect the eggs and then do the process, and that can be very tricky in women with severe endometriosis. So these are all fine things that we need to tune before going into the process.
Yeah, so it's good if you are looking into IVF and you suspect you've got endometriosis, it's good to maybe have a definite, go to the hospital and get checked out for endometriosis first as well, I guess, because then you know you've 100% got it. It kind of makes it easier for the treatment.
It does, and I think the endometriosis diagnosis is usually by surgery, so some kind of laparoscopy, and that gives a huge amount of information, whether there's endometriosis there, what your ovaries are doing, where they're placed, and so all this information is really vital for IVF anyway, and so that kind of full MOT, for a better word, is really good before we start treatment, just so that we know where we're starting off with.
Yeah, definitely. So the last question is, what is something everyone should know about IVF that isn't well known? Quite a hard question.
We talked about this, didn't we? Well, I think that what me and Charlene were saying was that I think people sometimes come into this thinking there is a guarantee of success.
Yeah.
We do get that quite a lot, that they're very disappointed that it hasn't worked for them because they're like, but I thought it would work. I thought that was, a guarantee that it would work having IVF. I think you just need to be aware that there isn't a guarantee, that the majority of the time it will be 50% that will actually manage to actually conceive through IVF.
Yeah, that's true actually. You do, before you have IVF, even me, someone that was thinking about IVF, kind of thought, oh well, there's always IVF. It's kind of like you always think, oh well, that's always there, that will work. But actually when you look at, the numbers of, the percentages of how many do work and how many don't, it's quite shocking when you because no one really talks about that side of it either.
And I think with older women as well, is that I don't think sometimes they realise, they just think that IVF is the answer, so that they can wait and then they can have treatment, because it'd be alright, I can have treatment after 40 because I'll just have IVF and I'll have a baby that way. It doesn't work like that.
No,
so
and there's a lot of stages to get through.
There is,
even to get to the embryo transfer, there's a lot of different steps and stages that you have to kind of tick off almost. That's what I found it like, there's a lot of different stages to get through to get to the
and I think that's a really good thing to do actually, is to take each thing step by step. So it's starting your period one step, starting the medication next step, getting to your scan, getting to your egg collection, don't try and think about too far ahead, if that makes sense, because otherwise it does mess with your brain a little bit and you're like, oh, it just becomes quite overwhelming.
Yeah, it gets quite stressful.
Yeah,
I think, doesn't
absolutely.
it?
So I think it's good to think, oh, I'll just get to this step and then I'll just get to this step and then it seems easier.
Yeah, take it a bit slower.
Yeah,
kind of thing.
yeah, definitely.
Okay, well thank you so much for answering those questions. Hopefully they helped anyone that asked those questions or anyone that's watching this that wanted to know some stuff about IVF. Yeah, it's really great to just have a bit of insider knowledge, so thank you so much. I'll leave the link below to Bourn Hall as well if you want to check them out. And we're also going to be filming a reel as well, so head over to my Instagram to see that, and you can also follow Bourn Hall on Instagram as well. So thank you.
Thank you.
Bye guys, thank you.